And now for something completely different, as they say. So here's the eye-catching slide that I think got a lot of people's attention several years ago. As you can see, there are 3 different patients. FFR was assessed in these vessels before and immediately after TAVI, and you can see that the FFR values change. And the question is, are these rare examples, or are these something that is more indicative of a systemic issue, and how can we understand what's happening here physiologically? And actually, these 3 end up being outliers. So this is the full data set from this group in Italy. You can see they did over 130 lesions. And the average FFR value before is equal to the average FFR value afterwards. There's no significant difference when you do a paired t-test. But that obscures something that's happening. And if you look at the points in blue, those are the ones that have high FFR values. You can see they don't change very much. But the points in red, the ones with lower FFR values, have a drop of about 0.05. Of course, anytime you measure something twice, you'll have a few that cross the binary threshold. But here you can see something that doesn't happen very often, 3 lesions that actually switched over the FFR gray zone. And so I want to explain to you why this happens and think about what it means for our practice. And the issue for understanding this has to do with the relationship between how aortic stenosis leads to left ventricular hypertrophy. As you recall, aortic stenosis increases both afterload and preload, so drives up wall stress, which is one of the major determinants of myocardial oxygen demand. And as a result, the heart then increases its thickness in order to bring wall stress and also myocardial oxygen demand back down. So that's the Laplace relationship. What does this do then to the myocardial bed? So we often talk very simplistically about myocardial resistance, but this resistance really has 2 parts to it. One part is the relationship between flow and pressure has a slope, so you can change that slope, but also that line has an offset that you can shift back and forth. And this is, just to be clear, is a relationship between blood flow down the coronary artery relationship to the coronary perfusion pressure during hyperemia, because during autoregulation, those 2 are kept in sync. It turns out when you create left ventricular hypertrophy, what you do to that slope is you shift it clockwise. That is, you have less flow for the same pressure. This was a very eloquent study where they did supravalvular aortic stenosis in a series of dogs. The amount of that rotation is related to the degree of left ventricular hypertrophy. You can see the LV to body weight ratio tracks very closely with the change in slope. You say, well, that's great in dogs, but I don't take care of many dogs. There's some great new data that's just come out looking at this same relationship in humans using intracoronary thermodilution measurements. This was a study looking at patients who had severe aortic stenosis, intact EFs, no major coronary disease. They measured myocardial mass by cardiac magnetic resonance imaging, and again you see this relationship, that the larger the left ventricular mass index, the less the peak stress flow because of this problem with left ventricular hypertrophy. The second issue that happens is that line can shift to the left and it can shift to the right. What happens when you develop aortic stenosis is it drives up LV filling pressures, and those LV filling pressures then shift that line rightward. So you have a higher coronary back pressure, and as you can see on the right-hand side, that back pressure relates to the left ventricular filling pressures. So here's what happens after we do TAVI. The red line is where we start off with, where the patient has severe aortic stenosis. When you immediately put in the TAVI, you reduce LV filling pressures, and so that line shifts to the right. And then over time, over the next several months, as the left ventricle remodels, that line then rotates upwards. So a shift followed by a rotate as you undo the 2 negative consequences of AS, namely left ventricular hypertrophy and high LV filling pressures. As has been seen from this data, it's kind of a pooled analysis of the partner trials. The more you can unload and reduce left ventricular hypertrophy, the better patients do. So take a look at the graph on the upper right there, the percent change in LV mass index from baseline. You can see that usually after a successful TAVI or SAVR, the percent change is about 20% or something like that. That's how much LV mass index reduces. It drops quite a bit, even within the first month, but it probably takes another year or 2 to fully regress. And the more regression you have, as seen at the bottom, the better your chances of avoiding all-cause death or hospitalization. All right, so that was LVH, and now we're going to take LVH and come back and link it to fractional flow reserve. And this has to do with how the coronary stenosis interacts with the downstream myocardial bed. We've been talking about the bed. That's that red line here on the graph, and I talked to you about how its slope and its offset are determined. But the other curve we have to think about is the pressure loss flow relationship for the stenosis, and that's what I'm showing you here in blue. So when you put those two curves together, they intersect, and the point that they intersect at is the FFR that you measure. So here's a fixed coronary stenosis in the purple curve, and where that touches the red line, let's say, for example, at an FFR of 0.8, that's what happens before TAVI. Now, immediately afterwards, you have a drop in LV filling pressure, so that line shifts to the left. You intersect the curve at a different point, maybe something like 0.76, and then over the next several months, as the hypertrophy regresses, that line rotates its slope up, and now perhaps your FFR might be something like 0.7. So this shows you how the same exact stenosis interacting with a myocardium that's undergoing changes because you successfully performed TAVI will lead to a different FFR because you can reach higher flows. However, think about what happens with a very mild lesion, right? There's almost no pressure loss flow curve, a very flat relationship, and so you really don't see much change at all in the FFR values over time. Just to emphasize, this was a great case example that I found published earlier this year. You can see the aortic valve hemodynamics up at the top, and then after aortic valve replacement, and they used cardiac PET to measure whole LV perfusion in cc's per minute per gram. You can see the two measurements in blue or at rest. No change in what happens with rest, right? This isn't a rest issue. This is a stress issue, and look what happens to the peak stress flow. Goes from 1.1 or so cc's per minute per gram, almost increases by 50% up to 1.5, and as a result, the myocardial flow reserve is also higher. This case example is really indicative of a very wide literature, and I'll just skip quickly through these slides. There's a lot of numbers on here. The purpose is to overwhelm you that there's a lot of data. I don't expect you to read these numbers, but to take away from it that many studies have shown that after TAVI and after SAVR, hyperemic blood flow improves in the short term and also in the long term out to 12 to 15 months. Resting flow, resting metrics, things like non-hyperemic pressure ratios or other resting flow measurements, really don't change very much. And just to highlight, it is safe to give adenosine even in severe AS. There's been many thousands of patients that people have studied about all this. There's a great study going on right now called Comic AS that's trying to put all of this together. So it's taking patients who have severe AS, they're coming for TAVI, they're undergoing a series of hemodynamic assessments, and you can see here a case example that they published where the FFR went from 8.6 to 8.2. Why did it change? Well, because the LV mass regressed and the LV filling pressure decreased after TAVI. And as I've shown you, those are the changes that then lead to intersecting the pressure loss flow curve at a different point. What do the guidelines have to say about all this? Oh my gosh, they're all over the map. So the ESC says that you should be focused on anatomy. They say that FFR has not been validated in patients with aortic stenosis. Of course, I'm not sure 70% diameter stenosis has been validated in those kind of patients either, but that's what the Europeans think. They do highlight, though, that there's a lot of ongoing randomized trials that still will let us figure out what to do. And then the ACC age guidelines, they let you do it all. If you read down there in the very third recommendation, it says you can use percent diameter stenosis, FFR, IFR, and they say there are no randomized trials to inform practice, so they kind of let you do whatever you want to. There are a few ongoing randomized trials comparing FFR against medical therapy in a Scandinavian study and against anatomic measurements in an Italian study. Those won't result for another year or two, and so at the moment we're left with some observational data from the Italians that really shows that FFR behaves the way it always does. It allows you to defer lesions and seemingly have better clinical outcomes, again, with all the caveats of observational data. One more slide before we talk about the other topic, and that's that if your reference standard is SPECT over on the left, you'll see that FFR has a superior area under the curve. And if you're wondering which non-hyperemic pressure ratio to use, if you look over at the data on the right, all of them perform the same when you compare yourself against FFR. All the non-hyperemic pressure ratios are about the same. I want to show very quickly a case because I was also asked to talk about bridging. This was a patient I took care of, a 48-year-old man who had dyspnea, came for evaluation. You can see the bridge in the mid-LAD segment. I also got a CTA. And the question is what to do about it. Is this the reason that the patient's having dyspnea? I also did an angiogram and some hemodynamic assessments during dobutamine. It's just impressive. When you give dobutamine, this thing almost completely closes off. You can see how that bridge becomes much more dramatic. And so I did a series of hemodynamic assessments. The first one is here on the left, taking the pressure wire, pushing it from proximal to the bridge to distal during adenosine, and you can see the FFR was 0.81. Then what I did is I turned off the adenosine, I turned on dobutamine, and I pulled the wire back through the bridge. And I want to zoom in and compare two beats. The one on the left is what happens during adenosine. The one on the right-hand side is what happens during dobutamine. And you notice that something a little weird happens here, right? Look at that coronary pressure. It actually gets higher than the aortic pressure when you go through the bridge under dobutamine conditions. And this systolic overshoot is one of the real hemodynamic fingerprints of myocardial bridging. You can see here some nice examples from the Stanford group focusing on how at baseline it was a gradient throughout the cardiac cycle, but that systolic overshoot is due to the bridge. And so here what I'm really highlighting on the left-hand side is adenosine produces a gradient throughout the cycle, whereas myocardial bridging produces a systolic gradient. And if I could use a bit of an analogy here. So you know the Brockenbrough sign, right, to distinguish aortic stenosis from hypertrophic cardiomyopathy. When you have a PVC in AS, your LV systolic pressure goes up, but also your pulse pressure goes up, whereas in hypertrophic cardiomyopathy, of course, after the PVC, the pulse pressure and the arterial pressure move in a different way. Similarly, with a fixed coronary stenosis, when you give a vasodilator, the gradient goes up both in systole and diastole, whereas with a myocardial bridge, the gradient actually disappears in systole and gets worse in diastole. And I'm showing you that here on this particular patient of mine, looking at these several beats. The ratio is actually greater than 1 during all of the systolic ones. So if you just take the whole cycle average, you'll be misled. Instead, we need to focus on the diastolic ratio, which in his case was 0.73. This is some of the best work that I've seen looking at understanding how that diastolic FFR performs related to stress-induced wall motion abnormalities during stress echo. And I'll just highlight that dobutamine seems to be the right metric. 2 more slides, I promise. What's fascinating is all those pressure measurements still don't relate to flow, at least in this particular patient. So I took him off the table. I brought him for 2 PET scans, one using dipritamol and one using dobutamine. And you can see that although he has these pressure gradients and a diastolic FFR around 0.73, his perfusion in the LAD is just fine, and his coronary flow reserve is just fine. So I ended up treating him medically and not sending him for any type of procedures. The guidelines actually highlight this scenario as one of these unanswered questions for the future. You can see here some of the quotes that they say that really there's a lot of uncertainty here. And I want to conclude by emphasizing the top quote, which is that most myocardial bridging is clinically insignificant. Thank you so much.